Thank you so much for joining me today. I'm Han Koehle, UCSB's health equity advocate, and I work at the intersection of student health, CAPS, and health and wellness to try to close health and healthcare gaps for UCSB students who experience structural marginalization on our campus. As we'll discuss in today's presentation, UCSB has made a lot of changes to increase care utilization and quality of care for trans students over the last 5 years. But once a problem is built into the infrastructure of the university, it can become very hard to solve. So today we'll be addressing one such problem in this presentation, misgendering and the electronic health record. In the simplest terms, misgendering is referring to somebody in the wrong gender category. So misgendering can include things like using the wrong pronouns for someone or calling them by the wrong name, such as using their previous or what some trans people call dead name. It can also include things like using gendered category terms like man or woman for somebody who doesn't identify with that category. So let's go ahead and look at some examples in a clinical setting.
Excuse me, Ms. Shepard? Hi.
Hi.
Welcome.
Thank you.
Come on in.
Here the provider misgenders Vanessa by calling her Mr. and then catches the error and corrects to Ms. And what I find really interesting about this example is you can see that the provider is looking at the chart and not at Vanessa. So this is something that the provider could have noticed up front and just wasn't really looking for it.
Okay. So, when was your last period? You didn't mark it in the chart.
I've been on T for 10 years. I've been on testosterone for 10 years now, and I've barely had a period the entire time, which is why the bleeding I'm having now concerns me.
Oh, I had a feeling, but I didn't know that for sure about transgender people. Thank you for telling me. How long have you been bleeding for now?
About a week.
Oh, I see. Well, if it's unusual for you to get a period, why didn't you come in sooner?
And I was kind of hoping it would go away on its own. I'm not really fond of gynecologists.
Yes, few women look forward to their appointments with me. Sorry, few patients look forward to the exam. Okay, let me take a look at you.
Here Jack expresses some anxiety about accessing gynecological care, and his provider says basically that he's just any other woman. And this kind of misses the substance of what's happening for Jack.
Have him change into this.
I don't want the blue one.
Well,
I hear someone's not feeling well. Let's take a look at the little man.
can I please talk to you two outside?
In this example, Bailey's name comes up correctly on her records, but her providers refer to her in misgendering terms by using he, him pronouns and referring to her as a little man. They don't notice her discomfort or her caregiver's discomfort and continue misgendering until the caregiver interrupts. In 2019, I teamed up with UCSB's Director of Health and Wellness, Dr. Charlene O'Brien, to expand our campus research into students, health contexts, outcomes, and healthcare experiences, including a targeted mixed method study of LGBT+ students. Of 197 participant students in that study, there were 130 who get at least some of their healthcare from student health and CAPS. In that group, 86% of cisgender students reported that they are always called by the correct name and pronoun at student health, and that goes up to 91% at CAPS. There are a couple of things that could explain the difference between CAPS and student health, and I think some part of that is that we know that people are most likely to be called the wrong name or pronoun in a higher volume area when they're being addressed by somebody who doesn't know them well. That happens more often at student health, whereas at CAPS, often if somebody is seeing their established provider, that might be the only person that they encountered during their time at CAPS. This gives us a sense of baseline. So we don't want to compare to the idea of a perfect clinician who never mistakes any of their words ever because we don't know her. So we want to make sure that we're comparing to sort of a reasonable baseline. And comparing cisgender students' experiences within the same context, I think, gives us a good baseline to start with. It's important to call all students, regardless of their gender or gender modality, by their correct name and pronoun. But like I said, we know that mistakes happen, even with people that we've known our whole lives and love dearly. So this gives us a sense of where our baseline is. We know that about 9 to 14% of cisgender students are sometimes called by the wrong name or pronoun, depending on where they're going and what kind of care. For trans students, however, this rate jumps up to 44% at CAPS and 68% at Student Health. And that means that most trans people who get healthcare at UCSB clinics experience misgendering when they try to access healthcare on campus. In our research, we got to hear about the specific experience of some of our student participants, and one student talked extensively about how misgendering impacted his experience at Student Health. And that means that most trans people who get healthcare at UCSB clinics experience misgendering when they try to access healthcare on campus. In our research, we got to hear about the specific experience of some of our student participants, and one student talked extensively about how misgendering impacted his experience at Student Health. My primary doctor, psychiatrist, and ADP counselor use my correct name and pronouns, but nearly every time I go to Student Health and interact with other staff, they use my legal name even when my name is clearly listed. This has happened while making appointments, getting my vitals taken, getting my blood drawn, and being called a girl, and in urgent care appointments where the person at the desk called out my legal name twice, even after I corrected them the first time. I don't often get apologies when I correct people, or they seem insincere. The day I started testosterone, the person there called a doctor to say something along the lines of, "She needs help injecting herself with testosterone." This is honestly infuriating and embarrassing, and it makes my experience at Student Health stressful and sometimes inaccessible. It just feels like there are systemic issues with people not being aware of or sensitive to trans needs. Another student reported, "I usually always get misgendered and dead named when I walk into Student Health. One experience I had was when a nurse called me by my dead name and then my name I use. She said she was justifying that it was me. I was outed to everyone in the waiting room." Outing someone means disclosing their sexuality or gender modality without their consent. It's a major breach of privacy and can put people in danger, so even in situations where danger doesn't arise, it can feel very frightening. Students also talked about gendering in positive experiences. One student summarized a positive experience in these words: "Staff ask for my pronouns. They use my correct name, don't comment on my dead name that shows next to my preferred name." This may not seem like a big deal, but this question didn't explicitly ask about names or pronouns. These were all write-ins, and it came up over and over. One of the things that we investigated in this research were student priorities for mental health, primary care, and sexual and reproductive health. We had a list of 23 different factors that we know can be priorities for people, and we asked students to choose up to 5 top priorities. What's really remarkable is that being called by the correct name and pronoun was the single highest priority for trans students. Out of all 23 of those options, about 2/3 of trans students put it in their top 5 for primary care, and over 90% of students put it in their top 5 for mental health. So why is this so important to people? Early empirical research on misgendering found that misgendering is strongly associated with felt stigma, and felt stigma is associated with participants feeling bad and having more negative opinions about their bodies. Participants who were misgendered really frequently in this research also had weaker identity congruence but stronger identity importance, meaning that people who experience their gender as being socially in question can experience more instability with their identity. But the identity feels more important than ever, and that's a recipe for distress. In the short term, misgendering can feel confusing, distracting, upsetting, embarrassing, humiliating, shameful. And in the longer term, that stacks up both psychologically and in clinical physical terms through its disruption of the medical encounter. So on the one hand, misgendering over the long term has been associated with anxiety, depression, and stress. But looking right at that clinical encounter, let's think about Jack. In that moment where he's on the exam table, he's already anxious about his gynecological exam, and now he's been misgendered by his provider. We saw on his face how uncomfortable he was. How will the rest of that encounter go? How many questions will he ask his gynecologist? How well will he remember instructions? How much will he trust his providers? It's not in the clip that I showed, but it had been 8 years since his last gynecological exam. How many years will it be until his next one? In our study at UCSB in 2019, we found that some students explicitly indicated that they had avoided care due to misgendering in the past. While this didn't examine misgendering specifically, the largest ever study of trans adults found that almost a third of trans people had reported putting off routine health care just out of fear of how they would be treated by clinical staff. Enacted and felt stigma like those found in misgendering are also linked to an increased risk of maladaptive coping and poorer health outcomes, including problematic substance use, social isolation, and even suicidal ideation. On the other hand, the use of correct names and pronouns is associated with a lower risk of depression and reduced suicidality. Because exposure frequency matters in how harmful misgendering can be, it's particularly important to prevent misgendering in residential and institutional contexts. In 2015, 14-year-old Kyler Prescott began having suicidal thoughts and self-injurious behaviors after experiencing bullying at school on the basis of his transition. Kyler's mother brought him to a children's hospital where she knew that there was a trans pediatric team, believing that this meant that all hospital staff would be gender affirming. During his 72-hour hospital stay, Kyler was persistently misgendered by hospital staff and patients. His distress and suicidality escalated, and Kyler died shortly after being discharged. His survivors sued the hospital for wrongful death and for civil rights violations. Ultimately, the suit was settled out of court, but this case illustrates why persistent or intentional misgendering has been recognized as unlawful harassment and a violation of patients' and students' rights under the Affordable Care Act and Title IX, respectively. Misgendering is usually talked about in terms of trans people, but the term originally emerged in the context of talking about feelings of alienation, confusion, and humiliation arising when people's genders were not intelligible across cultural barriers, particularly in the context of ongoing colonization. The psychological responses described by the targets of misgendering in these contexts closely mirror what we observe in more recent studies of trans people, and that suggests that this effect isn't unique to trans people, and neither is misgendering, although many people mistakenly use it that way. But when Indigenous boys with long hair are pushed out of men's bathrooms, or Black women who excel in sports are implied to secretly be men, this is also misgendering, and we can expect it to have some of the same deleterious effects. This fall, a research team led by medical informatics researcher Dr. Clair Kronk published new research on the relationship between negative experiences of trans care seekers and data representation in electronic health records. The team explains that limitations within EHRs can create barriers to care for patients by making negative encounters more likely and creating unnecessary difficulties for care providers. For example, the team points out that in most EHRs, the only way to record that someone is trans at all is to put it on the problem list, which contributes to felt stigma by expressing trans identity as if it were a disease. Many EHRs also use antiquated and even stigmatizing language for trans identities, forcing even affirming providers to label patients as FTM or MTF or even other in records. I sat down with Dr. Kronk to discuss the team's findings.
The very first thing you see for a lot of encounters is going to be that intake form. And the way that you avoid potential medical harm is by picking up on as many early cues as possible. So it's very important for the first people that are interacted with, the first people when you're coming in, to have an idea of what's important and necessary to build a comfortable space.
In many cases, systems don't readily support adding information like a lift name or pronoun, making it difficult to record and retrieve the information necessary to address patients with dignity. At other times, these modules are available only on an opt-in basis, but they're tucked out of the way, and often providers don't prioritize these areas of the health record, especially in higher volume contexts.
Social history is not typically filled out. I usually see it opt-in mostly in endocrinological and psychiatric wards. It typically doesn't reach much practice outside of there. You might see it in pediatrics, but for instance, emergency medicine, cardiovascular, you're probably not going to see it much as an opt-in. And even if it is opted into as a hospital policy, it's just not going to be filled out.
When this information is not recorded, not displayed prominently, or not utilized, it can quickly send the message that patients cannot trust their providers.
Preponderance of misgendering can be a signal to an individual that they might be more likely to be a victim of a hate crime, of harassment, of discrimination. And so oftentimes this kind of signals a fight or flight response. You have to see this as kind of a degradation of a person's core identity. I see oftentimes in care where a front end worker misgenders a patient, and the patient, rather than having the provider potentially come out and call the wrong name or use the wrong pronoun, will just leave and not access care at all. And so usually that's done because of a perceived safety risk, which may or may not be an actual safety risk. And so that's important to consider when you're providing any kind of care.
When patients' needs don't fit within the programming logic of the EHR system, it can make things a lot harder for providers as well.
Our usage was mostly to prevent EHR rule-based systems from breaking and providing inaccurate routes of care. And so most EHRs have anywhere between 10,000 to 40,000 rules that are in the back end. Most people who are providers only see these when they are pop-ups or alerts, which everybody hates. And we see in a lot of trans and intersex care that alert fatigue or an overabundance of alerts is more common because sometimes procedures or labs will not be accepted with particular, in most EHRs, you only have one datum called administrative gender that is used for all of the rule-based determinations. And you might run into significant problems with those. So you might have to switch EHRs back and forth, which can cause a lot more alerts to pop up, most of which might be inaccurate. And so what we were hoping is that we could use this as a better proxy to help guide some providers who don't have trans or intersex specific care into, hey, maybe I should use this reference range instead of this one. Or maybe this procedure that I've been trying to get, let's say you have somebody who is a trans man who is legally male, who has transitioned all their documents, wants a hysterectomy. It's not uncommon for somebody to submit for a hysterectomy and for somebody to say, well, the legal sex is male, so it's impossible to do one. This must be a mistake. And so it will be sent back. And then the provider has to switch the EHR from male to female, submit the request, wait for it to come back, then change everything back. And that is a very painstaking process. And we just want to decrease the amount of time the provider has to stare at the screen.
It's difficult for some providers to understand why this demographic data matters.
To a certain extent, I can understand why an oncologist might be like, look, I treat cancer. I just want to treat the cancer. Cancer is the same for every patient. But unfortunately, we know that there are some environmental differences. There are public health related differences here. There's stigmatization, there's marginalization, there's lack of healthcare access, and these things need to play in to treatment regimens. Otherwise, you're going to see massive disparities in mortality and morbidity.
On the patient side, these rule breaks can cause automatic insurance denials based on gender, which can be a violation of the ACA and happens often for trans and intersex people. These false denials can mean that it takes more time to access services, and in some cases, it means that those services cost a lot more even when they should be covered. And that's a major problem for groups that are disproportionately likely to face employment discrimination and poverty. It also introduces opportunities for new errors that can further erode trust. For example, if a provider has to manually change the sex of a patient to overcome bounce backs, they might forget to change it back, leading to a nasty surprise for the patient down the road. Currently, Point and Click doesn't support a lot of the changes that the team recommends, which leaves us in a position of needing to work around a system that makes giving good care harder. In 2017, Student Health Problem Solvers introduced a workaround using the nickname field, where the student's lived name could be entered through the patient portal and would show up to the right of the legal name at the top of the chart. Then in 2019, the campus rolled out a lived name system, and this allows students to enter their lived name through campus identity in gold. In 2020, the campus added pronouns to gold as well. So now a student can enter their lived name and pronouns in gold, and they'll show up on rosters, on their student ID, on virtual classroom tools, and that same information will feed into our nickname field, which is awesome because at first we had two separate systems and it was so confusing. In most of the campus, though, the legal name isn't visible at all. This is treated as FERPA-protected data and available only on a need-to-know basis. When we added lived name to our clinical documents, we were among the first places on campus where this was possible, and one of the places where it was easiest for students pretty soon to enter their own name. We could also help students by entering the name for them. So if a name was different from the name that the student introduced themselves, we could say, hey, do you want me to just go ahead and update your record? But now, since the name feeds through gold and is all over campus, it's kind of the flip. Now we're one of the few places on campus where the legal name is visible. In most of the university settings, the legal name isn't necessary, and so nobody sees it. It doesn't show up at all. And so for a campus affiliate who's, for instance, a TA, they'll see their roster and they have no idea which names are legal names and which names aren't because it's not relevant to them. Because we have medical billing, and that does require the legal name currently, we see the legal name. But because of the current system that we're using, we see it first, which means on our end, students are more likely to be misgendered in a clinic than they are in a lot of other parts of the university. And that stands to erode trust pretty seriously, because from the student perspective, we're all seeing the same thing and we're making a different choice about what to do with it. We know that that's not true, but we also know that our students won't know how many different systems are being used on campus.
Doing things like you are doing are, like a small band-aid on a much larger problem that might only be able to be solved by putting pressure on an EHR company or vendor.
There have been some pushes at the national level in the recent years to address how EHRs record gender and sexuality, to both fix the issues caused by misgendering, as well as those caused by alert fatigue, mismatched reference ranges, and inappropriate rejections of coverage. In 2015, the Centers for Medicare and Medicaid Services published a mandate that health IT modules must allow patients to record, change, and access information about sexual orientation and gender identity. However, their gender requirements listed male, female, and unknown. This list doesn't actually resolve much confusion, as it remains a single variable that refers to many different factors in healthcare. For example, I'm legally non-binary, but I have a binary marker on my insurance card because my insurance provider does not recognize my gender. Medically, it would be appropriate to use female reference ranges for some elements of my care, but male references for other elements. If given a single checkbox, am I telling you my identity, my legal status, my billing information, or my care needs? And if my care needs, which ones? In November of 2019, the American Medical Association amended its EHR policy recommendations, stressing the importance of collecting more expansive gender variables in order to identify and address the specific needs of trans people. They addressed some of the pitfalls with the 2015 system. Using male, female, unknown didn't actually make it easier to identify or meet the needs of trans patients. And the unknown or other category was undefined in the system, making it virtually unusable. A fix to this problem is using a two-step approach to gender data collection.
In terms of our usage of the two-step, which is asking for gender identity and assigned gender at birth, which is typically in the United States and Canada related to birth certificates or birth registries, although not always. Now, granted, this doesn't solve all problems. We're replacing a single-step proxy with a multi-step proxy.
The 2019 AMA recommendations included collecting preferred name, what we call lived name on our campus, gender identity, pronoun, and what's called an organ inventory.
What you actually need for care in terms of things like organ inventories, hormonal profiles, those are something that we're working towards. And I think a lot of EHRs are starting to implement that. But right now, that's a little bit of a higher ask. We often deal with a lot of patients who might not have a base knowledge of their own or of medical terminology. And so that might be a confusion point more so than a helpful point. And then what we dealt with is like some providers saying, well, I want to make sure that this person has X anatomy. And then you have a very invasive series of potential screenings. And so there are other issues with that. And so starting small scale, I think with things like organ inventory can be great.
Little did we know there wouldn't be much time to put these policies in action.
I have today declared that the coronavirus presents a public health emergency in the United States.
There were really long response times in the AIDS crisis and when SARS was first appearing. And so luckily, a lot of standardization boards were very quick with their COVID recommendations and have been updating them almost monthly.
UCLA's Williams Institute and others warned that known health disparities, including elevated rates of housing and food insecurity, elevated tobacco use, and prevalence of asthma, cancer, and HIV, would likely mean that trans people would be hit hard by the pandemic. But because so few systems were prepared to even recognize trans patients, data was missing. In July of 2020, California issued emergency regulations that called for data collection regarding sexual orientation and gender identity for all reportable diseases, including COVID-19. But more than a year later, that data remains missing. Systems are now required to report the data that they have, but in most cases they were never collecting it. So in a lot of ways, even after early warnings about likely disparities and new reporting regulations, we just don't know how big the gap really is. And that means nobody's really working to close it.
If you don't count us, we don't count. And having that health disparities information is really important because there might be underlying patterns that you're not seeing. We learned very recently, for instance, that there was a scanning operation, I believe for melanocytes or melanocytic cancers, where we didn't notice that the scanner being tuned mostly on white people was not working in Black populations. And we didn't figure that out until race was recorded. For LGBTQ people and trans people specifically, this means a lot of formalities of care, of bedside manner tend to hit the wayside as low-hanging fruit sometimes, which to a certain extent is understandable. If you're seeing 200 plus patients in a day, the ability to remember any of their names is something that I will give kudos to any nurse for. However, there are methodologies to help prevent those sort of issues.
Early on in the pandemic, researchers recorded big jumps in mental health symptoms among trans people, tied to losses in access to routine and specialized care as resources were redirected toward crisis services. Trans people who had been working for years to access gender-affirming care suddenly lost that access, and at the same time, they were losing access to HIV testing, PrEP, and substance use counseling. In more and more situations, trans people simply had nowhere to turn. At the height of the first big wave in the US, state lawmakers across the country introduced new bills intended to reduce trans people's access to health care. One bill in South Dakota even sought to criminalize providing transition-related care to minors. This bill would have made this a felony, carrying up to a 10-year prison sentence for healthcare providers. In June of 2020, the federal government withdrew guidelines establishing that it is illegal for healthcare providers to discriminate against trans people on the basis of being trans. In addition to the harms of blocking access to healthcare services, especially during a global health crisis, the loss of civil rights also constitutes a major detractor to well-being. Trans Lifeline, a crisis line staffed entirely by care workers who are themselves trans, reported a 40% increase in crisis calls between the first US COVID cases and the end of the summer of 2020. But the high point was immediately following the removal of federal healthcare protections. In 2021, state legislators upped the ante, introducing over 100 anti-trans bills across the US, primarily targeting trans healthcare and trans participation in sports. More anti-trans legislation was introduced in 2021 than any other year to date. Some states already had their own state-level protections, so it doesn't seem like the reduction of federal policies would make that much of a difference. But trans people across the United States woke up to learn that they had lost the right to go to the doctor. And many trans people were experiencing denials even when it was illegal. So there was a lot of fear about what would happen now that it was legal to deny care. The reversal of this policy came only after 11 long months, a span of time in which 500,000 people in the US died of COVID-19. Locally and nationally, trans people are being excluded from care at a time when the impact of that exclusion is vastly magnified by the pandemic. Ultimately, addressing this problem will require actions at lots of different levels. So let's talk about what will be required and what we can do, both as a unit and as individuals, to help. One of the most important elements is two-step data collection for gender information.
The issue is that multidisciplinary teams to help playtest these things first before wide implementation were not there. And so instead of this slower, gradual uptake to the point where everybody considers it routine, right now we have very, very select opt-in based on self-selected education and training. People who want to be allies or who are part of the community themselves are the ones who implement it. And that's it. They might encourage their colleagues, and we're very grateful for that. But as a large-scale implementation, that's not a solution.
At the campus level, we can prioritize vendor relationships with vendors that do meet those AMA recommendations. And we can make some changes to the system we have now to make it work a little bit better.
Fenway does their own custom instance, I believe, of Epic. And they've basically got it to the point where they just make the font for what they want it to be seen like 20 times bigger. And so the name to be used, which is the terminology that I've been using, or name to use, will be like font size 20 or font size 32. And then the legal name might be font size like 12. There's usually a box in one part of the corner that just has a pronoun in really, really big font in a jazzy color. So it's impossible not to see. I like the idea of font size change or color changes. You do have to be careful, for example, for color blindness when selecting any sort of color palette.
Another change we can consider at the campus level is checking in with what lists structure our use of standardized terminology. We can ensure that we're using the most up-to-date available lists that are really designed with patient needs in mind.
I do not have a good working relationship with SNOMED because of intractable differences and their inclusion of individuals from transphobic hate groups on some of their expert panels has been difficult. So I would recommend leaning away from SNOMED for those systems and potentially leaning towards modified LOINC lists, which are more commonly used in the UK. Now you might not have control over which lists you can use, but it's always worth talking to your database admins and administrators and your EHR point person in your institution. Hey, what can we do? How can we push up changes?
We made some pretty major changes to our intake forms when we started this process a few years ago, and we've made some minor adjustments since then. That's the kind of thing that we want to keep doing and keep evaluating every year to make sure that as our community's needs change, we're keeping up with them.
You don't have to hire a new person who goes through this maybe more than once a year, but who, your intake in your community is unique to you, and people around you in that community might have different things than the base recommendations. So in the paper, we provided kind of a basis. If you have the people to do surveys of patients, that's best case. But especially right now, I know that might be difficult or not possible. And so ad hoc sort of, after they've, signed up or whatever online, if there is a feedback form where they can say, I hate this, or this is bad, I think that can help kind of inform changes in the future.
Now, we don't have to have a whole new system for this. We already have patient feedback forms, but it would be a good idea to have some explicit questions about our intake forms or about our patient portal so that students have an opportunity to give us that specific feedback. This feedback can help guide continual improvement to ensure that we're providing care that is congruent with our local community's needs.
Additionally, doing sort of data, collection feedback over the course, maybe bi-monthly, depending on if that's available, to look very briefly at, base demographic statistics of your population. I think that can be helpful for trying to allocate care areas.
Since we already have a committee at UCSB for health equity initiatives on campus, we have built-in capacity to evaluate and draw up recommendations based on this data. All we have to do is start collecting it. Collecting equity data at the local level helps guide care allocation and reflection of campus values, and it can also help contribute to the crucial playtesting of these systems to ensure that national standards meet the needs of patients and providers.
I think there's the bottom-up approach and the top-down approach. And I think given how much providers, at least in my experience during the pandemic, have been overworked and in some cases underpaid, I don't know if I can say that, but I don't want to throw you into what I usually do, which is the top-down approach of going to medical standards boards, going to 10 hours of meetings per week. Like, I don't want to do that to people. I really think trying to become an example and slowly implementing it into your work, becoming kind of a point where, somebody's at a conference or something and they're like, oh, we heard that you implemented this. How did you do it? It's going to mean a lot more for a nurse to say, I implemented this and I'm giving better patient care and my patients are doing well. We've collected some great data. We've published some really good results using that data that we collected. I think that will speak more to individual experiences.
Core part of our bottom-up strategy at UCSB is educational experiences like this one. But this works in part because so many of our staff are unionized, and we're not in the situation of, like a lot of clinics, relying on unpaid outside work hours trainings that really only hit a small proportion of staff, or worse, can actually create feelings of resentment toward the group that it's meant to help.
I find, at least in my personal work, that providers, once again, are overworked. And if you tell everybody, hey, we're going to have a 3-hour seminar that you have to come to on Monday at 6 a.m., and then you only promise like there might be coffee, people will self-select, who are already probably pretty affirming. And that's really not who we need to reach. You as providers should be dictating the systems. The systems should not be dictating you. Unfortunately, I know that paradigm has become reversed recently and can feel alienating, both from your patients, from your systems personnel working on the back end. I genuinely think things are getting better and that we can hopefully reduce screen time. I don't want to add any sort of 3-hour long, seminar on here's how you use this newfangled system. It should be implicitly usable, and that's what we're aiming for. But your bedside manner, your ability to help patients, to treat them as human beings, to have your personnel on all levels, treat people respectfully, speaks a whole heck of a lot more than anything I can put into an EHR.
So far, we've talked a lot about what needs to change at the level of management and the system. And that's because at its heart, this is a system problem. We know that it doesn't work for patients to simply have to rely on luck and hope that they get a clinician who's affirming. And then, in the best case, have the patient and clinician work together against a system that makes it difficult to access care. Instead, we need to have that care access work by default and have the easiest pathway be the one that really supports the student's well-being. While a lot of what needs to happen can only happen at that management, unit, and system level, there's still lots that we can do as individuals to help. And one of those things is to understand how those structural factors impact individual students so that we can help them get through the process and navigate the system with as much dignity as possible. One of the most important things we can do in our clinic to reduce felt stigma is to refer to each person respectfully by calling them by their proper name and their pronoun. Calling people, patients, colleagues by their correct name with correct pronunciation and their correct pronoun communicates respect and enhances trust. Ideally, we'll address all patients and colleagues by their correct name and pronoun in every encounter. And there's 2 ways to help make sure that this happens with patients. First, if you're looking at the patient's medical record, check for parentheses next to their name. That parentheses might contain information about their name of use or their pronoun. If a lived name is listed, do not use or disclose the legal name unless it is legally necessary to do so. If a lived name is listed, never use the legal name out loud in a public space such as a waiting room. If you aren't sure how to pronounce the student's name, ask. Never use the legal name to avoid saying a name you aren't sure how to pronounce. Instead, proceed in the same way that you would if the legal name wasn't there. And then if you're face-to-face with a student, incorporate names and pronouns into your introduction. So I might say, hi, I'm Han, I use they, them pronouns, and then give the student an opportunity to introduce themselves and listen. And if the student's name is different from what's on the sheet, there isn't a parenthetical, you can let them know, hey, if you want that name to show up for us, you can update it in bold. Of course, this isn't just relevant to trans students. Lots of students prefer to go by a nickname, by a middle name, or another name. And a lot of those students have never had the opportunity to be called the name that they really go by in a healthcare environment because it just never came up before. So this could be something that can really help people connect and feel seen in a healthcare environment in ways they've never been thought about. Now, often when people do a warm handoff, they won't do this step because they think that, oh, this person is introducing me. But the person who does the warm handoff might have forgotten to check in or might have made a mistake. So it's always a good idea to introduce yourself and give the student an option to disclose their name or their pronouns again. Now, the most common pronouns we see at UCSB are she, her, he, him, and they, them. All UCSB employees should be familiar with these pronouns. Some students use a mix of pronouns like she, they, which means you can say she came in today or they came in today. Both would be correct. Some students use no pronouns, and so for these students, it would be most appropriate to call them by their name anywhere that you would put a pronoun. So, Josie came in today for Josie's appointment. If you want to learn more about pronouns or get a chance to practice using some pronouns that you're a little less familiar with, the Resource Center for Sexual and Gender Diversity right here on campus has some great resources on their website. Another resource that I love is pronouncenames.com. This site has audio recordings of names from around the world, including a lot of unusual names. My first and last name are both pretty unusual. I've never met somebody with my last name that wasn't a direct relative. And people don't know how to pronounce it, but you can even look me up on there. If there's a name that you run into a lot that you aren't confident about, this is a lifesaver. While I'm focusing mostly on misgendering and how that impacts trans people today, this is also an issue for Black students, Latinx students, API students, Native students who feel unwelcome on our campus if their names are consistently mispronounced and they see their white colleagues' names not being mispronounced. So using these kind of tools, I'm thinking about we all want to be addressed with respect and dignity, and our names are a really core part of that. It's not a special thing for any one group. It's just something that not everybody gets yet. Now, in an ideal world, the data will always be present, readable, and correct. We'll notice it, we'll use it correctly, and we'll never make any mistakes, and all of our dishes will be done by fairies. But that is, of course, not the world that we practice in. So mistakes will occur, and with any error that could be harmful, the best thing we can do to reduce harm and to restore trust is to respond quickly and in a way that honors what's important, which is treating the patient with respect, and then getting back into the care encounter without lingering over long about what went wrong with it, because that can just create a lot of awkwardness. If the best case scenario is no mistakes, the second best case is that you've made a mistake, you notice it yourself, and then you clean it up. So some great examples of this come from those first two clips we saw right at the beginning of the video. In both cases, the provider made a mistake, said Mr. instead of Ms., said women instead of patients, noticed how it might be impacting the patient, and immediately corrected, and then got back into the encounter. Now, that isn't no harm, but it is better than some of the other ways that this could go down. That third video we saw, however, falls far outside the second best category. In this video, the providers did not notice their mistake and had to be told by a patient advocate, hey, let's talk about what's going on. Now, it wasn't in the clip that I showed you, but in the fuller version, they did actually adjust after that. And so this is still not second best, but third best. If you don't notice the mistake yourself, the next best thing that happens is the patient tells you that something's going on, or their person with them tells you that something is going on, and you can respond in the same way that you would if you had caught it, with an apology, a correction, moving on. Now, the worst case scenario is like in the Tyler Prescott case, where people received feedback and continued to behave disrespectfully towards the patient. In this case, this can be intensely harmful and open the clinic up to significant liability. The bottom line is that everyone who walks into our clinic deserves to be treated with respect and dignity and to have their privacy protected. This is reflected in our clinic policies and in state and federal law. And as we continue to make changes to honor these values, we expect every staff member to take an active role in upholding these important values and demonstrating that respect and dignity towards all students and colleagues. Thank you so much for joining me this morning, and I hope that you all have a very safe